I would like to introduce Dr. Firas again and welcome Dr. Firas. I don't want to take more from your precious time. I want you to enjoy this time, and I promise you with a very nice gift at the end if you stay to the end of this webinar. Thank you very much. Enjoy. And if you have any question, you can write it in the chat box. Thank you.
Thank you, Dr. Ahna, for excuse me. Thank you, Dr. Ahna, for your introduction. It's always a pleasure to meet with you. I understand we have a large audience from all over the world. So for those who are starting their day or still having or enjoying the daylight, I would say good morning. For those who are done with their day and it's time for them to relax, I would say good evening. My name is Dr. Firas Al-Khatib. I'm a dentist and a specialized orthodontist. I graduated from Damascus University with a PDS degree. Then I specialized in orthodontics from University of Paris 6 in France. Then with a diploma degree, then I got my master's degree in from Austria, from the Danube University. And I also hold a DMD degree from SIU, Southern Illinois University, where I teach orthodontics currently. Besides teaching, I practiced and still practicing orthodontics between Saudi Arabia and United States. And I'm also the founder and the program director of the Master Clear Aligner course in collaboration with Mastery Academy Institute. In 2001, when I was still a resident in Paris, specializing in orthodontics, two ladies came to our program and they made a short, brief presentation about the Invisalign system at that time, introducing the first clear aligners the way we know it today. And Align Technology at that time was relatively new company. And I still remember until now, until this moment, how impressed I was when they made the presentation, they explained their concept, and when they shared their software. And I have to admit, at that time, I was still fresh in the world of orthodontics, but I realized that I was in face of something big, and it's a revolution in the way orthodontics is being done. Even though at that time, clear aligners were only able to manage simple cases from mild to moderate crowding or spacing, but with time, orthodontists and dentists who were excited about the new technology added their experiences and creativity to that technology and started expanding the spectrum of malocclusions that can be treated with clear aligners. Patients also became aware of the technology and started asking to be treated that way. Many corporates, many companies that are specialized with the orthodontic products knew and understood the potential of this technology, and they started launching their own clear aligner line of production. And today, the demand of clear aligners is just booming. And to know that orthodontics or orthodontic programs all over the world and here in the United States started training their residents how to treat clear aligners. Some dental schools, even like here in SIU where I teach, we started teaching dental students how to use this technology because depending on the regulations of the country, dentists here in the United States can do orthodontics as long as they have the knowledge and the experience required to do these kind of treatment. And actually, most of the providers here are just general dentists. And of course, we teach them just what is in their spectrum of experience and what they can manage. I personally started treating patients with clear aligners in 2005, and I have to admit that my beginnings were not very smooth. I struggled a lot, and that struggled to finish the cases, to get the results I wanted, especially when I compared my work with the work I was able to get with clear aligner, with the brackets and wires. I had failures, which pushed me even to learn more and overcome them, and then learn more how to avoid them and to be able to manage and treatment plan my cases in a very predictable way. Today, I'm still learning and improving with every case I'm treating, with every case I'm helping someone to treat. And as you know, clear aligners have some advantages, especially when you compare them to traditional braces, but mainly they are more aesthetic, they are more hygienic. patients don't have to change their lifestyle for orthodontic treatment anymore, which made clear aligners a very acceptable treatment option for adults. And because of that, it's not only easier now and at too many levels to consider orthodontics as part of the patient's comprehensive treatment, but it's not only done for aesthetics now, but also for restorative reasons. Today, I'll be sharing with you the type of cases that I think orthodontics would be very beneficial to the treatment outcome and can be easily managed with clear aligners. Considering orthodontics as part of the comprehensive treatment plan not only helps you deliver better and more predictable treatment plan for your patients, but also digitalization make it easier for you to communicate with the patients and make your practice more profitable. Our audience today is diverse between orthodontists and dentists, and that's why my presentation would be focusing on both groups. We start with the dentist first and what are the things that probably they are able to manage, and then I'll save the more and the complex things for the orthodontist. And the questionnaire and the questions that you answered, and thank you for doing so, you give me a clear idea about how clear aligner market is in these days. And to be honest, I'm not very surprised with your answers, because myself, when I started with clear aligners, I had problems designing my cases and getting predictable outcomes, especially when it comes to the digital treatment plan. I'll be sharing some tips today, but today mainly we will be talking about how the clear aligners should be part of the dental practice and the orthodontic practice. So the topics I'll be covering today is a quick introduction to the clear aligners, just briefly going over the the process overview for those who are not really familiar with the clear aligner therapy. We'll talk briefly about why clear aligners is a revolution in orthodontics. Then we will talk about the cases that I think general dentists should be aware of and should be able to manage with clear aligners, and how having or adopting clear aligners in their practice would help them to achieve even better outcomes and serve their patients better. And for my dear orthodontist, I'm saving the more complex and more interesting cases, or kind of cases that they should consider, or that are probably easily managed now with clear aligners, and why they should always look into that option when they deal with their patients. So for those who are not really familiar with the clear aligner therapy, what is clear aligner therapy? Briefly, it's just a series of clear aligners made of a special kind of plastics, usually thermoformable plastic, and they are designed with the help of a specialized software. And with these aligners, teeth can move gradually until the desired final position is achieved. Usually that final position is being programmed using or with the help of the software itself. Each aligner usually is designed to move the tooth for 0.1 to 0.25 millimeter. If we look at the process itself, how it starts, everything starts with a consultation. And these days, especially with clear aligners, these consultations can be done even online or virtually. And once the patient comes for the records, this can be done using digital means like CAD-CAMs or 3D scanners, or with the PVS impressions, which will be then sent to the company or the lab. And using the platform, you can communicate with the lab technician or the specialist who is designing your case, and then you can work together on the software so you can design your case. Once the treatment plan is approved, then the manufacturing process starts depending on the company or the lab. There are different ways of doing that, but generally they just print the models and they press the aligners with some kind of thermoformable plastic on them, and then each aligner will be packaged individually, and they will be all shipped to the clinic all together. Once they are received, the dentist will call his patient, where they start the process by bonding the attachments, doing the necessary IPR if needed, and then they give them a certain number of aligners that the patient will be able to switch at home. And then the dentist will have to monitor the treatment in a certain intervals, usually 6 to 12 weeks, depending on the case, and check how the treatment is going. And once everything is done, and if everything is going well, then we check, once we reach the final set of aligners, if the treatment is done. If both the patient and the dentist or the orthodontist are happy with the result, that means this is the end of the treatment, and they can deliver retainers. But if not, then they can go for another round of aligners, which is not very uncommon, or what we call them the refinement set, where they can take new records and ask for a few more aligners just to get the case done. I want to start with something and emphasize on this, that clear aligners is a treatment and a technique. It's not just a product. And what I mean by that, although that Invisalign is the elephant in the room, and they are the biggest company, and they are the one who made clear aligners the way we know them today, but what treatment with clear aligners involve its own techniques, its own biomechanics, its own way of thinking. So it's not just a company. And many companies, and this is just a short list of the companies that are making clear aligners these days, jumped to this line and started fabricating and offering this service. Beside local labs, both systems that can make or fabricate the clear aligners in these labs without going to the big companies. Some orthodontists even started making in-house aligners, meaning they design their own aligners in their offices after training their staff, or they are even involved in this process. So again, what I want to say that clear aligners is a technique now. It's just like for my dear orthodontists who are aware of all the systems, just like a straight wire or even the tweed technique, clear aligner is a new technique by itself. That was the big question always in my mind when I started treating with clear aligners. How do they work? Was it simply just that we make different models where we just move teeth gradually with each model, and just we make a new splint or new aligner at each step, and teeth will just follow that new shape and will be aligned the way that we want and we desire? I mean, to be thinking this way probably is not very wise. If the treatment with clear aligners is that simple, then I think all treatments are easy now, and with time, the role of the dentist or the orthodontist will go away. And honestly, this is not the way that clear aligners work. Those who treated, and there are many of you who are still in this room who treated patients with clear aligners, know exactly that this is not what you get. In the exception of the straightforward cases, the easy ones, the simple alignment, the cases don't go that way without the proper management, the proper treatment planning, the proper digital treatment planning, and understanding the mechanics and the staging of the movements of the teeth with clear aligners. But to break it down and to make it easy for you, there are three main elements with the clear aligner therapy. The first one is the software, and this is where all the magic happens. This is where you start designing the case, decide what is the final outcome, decide how you will stage the movements, decide how you want the teeth to look at the end, decide where and when and what kind of attachments you want to place. And this is where you really communicate with the technician, the lab, or whoever is working with you in that case, or even if you are working alone in that case, this is where everything happens. Then the second element is, or are the attachments themselves. And there are two main things with the attachments is understanding how they work, understanding when and where you should be adding them, and designing them on the software. And the third element is the plastic aligner itself, the material from which the aligner is made. Different companies using different material, and of course each material has its own advantages and disadvantages, and all three elements are interconnected between them. So the software is being used to design the attachments and decide the shape of the aligners, because with every step, each stage that you design on this with the software, you affect the way teeth will move. And remember, and this is very important, the change in the aligner between the stages does not mean that this is how the teeth will move or the teeth will track that way. It just means the difference in the shape of the force, or the difference in the force that you are delivering with each aligner. And hopefully, if you design that properly, the teeth will track and will follow that design that you made. What we are looking at here is just four different screenshots for four different softwares that are used to design clear aligners, starting from the one on the upper right corner, which is the Invisalign software. This is the Spark aligner from Ormco. This is the one from 3M, and this is another one from Archform company, which is an open source software that are used with the labs. And the reason I'm bringing this up is just for you to watch the similarity between these three softwares. Basically, they are all made for the same reason, where you can design, look at the treatment before and after, how you are designing or staging the different steps for the treatment, adding, removing the attachments. So the interface might look a little bit different, but they work in a similar way. So keep that in mind. And my other question for you is why clear aligners? Why we choose this topic? Why I felt that clear aligners is something important? And I don't want to spend much time here talking about the advantages and disadvantages of clear aligners, from aesthetic to hygiene to all the things that you are aware of. I just want to focus on one thing, is that clear aligners are shifting practice towards digitalization more than ever. And that this digitalization is starting from the very beginning with acquiring the records, because for the most part, those who are involved with the aligners now know how important it is to have a CAD/CAM scan. CAD/CAM scanners are becoming the big thing in the industry whenever they are replacing impressions, but this is even more important when you are working with clear aligners now. So that process is starting from acquiring records, from designing the case with the lab, from communicating with your patients with the technologies that we have now, to the fabrication process. So the whole process from A to Z is digitalized, and it helps you digitalize your practice and think digital. And we'll see how thinking digital really helps in dentistry these days. I always like the example of cell phones. The one on the left side, most of you know it. This is the legendary Nokia 3310, if I'm not mistaken. And this is exactly the mobile phone that I had when I was a resident, when I was first exposed to the Invisalign system or the clear aligners at the beginning. And on the right side here is the one I have today. And you can imagine the difference between these two in about probably less than 20 years. The only few things that we could do with this phone is just receiving and sending calls and text messages and playing probably the famous snake game on that. That's about it. I can't remember that I could do anything else with this phone. But with the new technology that we have, with the new development, I mean, you have your laptop, literally, you have the Word in your pocket. you can communicate. Many of you are now watching me just from their phones, which is something we couldn't imagine 15 or 20 years ago. And where I want to get with this is that because of the digitalization and the involvement of computers and artificial intelligence in clear aligners, you can imagine where clear aligners and the softwares are going to be from now on. This technology is going to be somewhere else in probably 10, 15 years, and only God knows where this is going to end. The other thing that I would like to talk about regarding the advantages of clear aligners is being able to visualize the treatment and treatment plan without doing anything in the mouth yet, and communicate that to the patient and decide which way you want to go. This is a case that I treated years ago, and when she came back to me, she had a relapse of a previous orthodontic treatment. Her main concern was the big overjet that she has and the class 2 malocclusion, beside the alignment of the upper teeth. And at that time, my big question was, how would I treat this? What is the best approach to deal with that? Should I just align the teeth without dealing with that class 2 and see how much overjet I will end up with? Should I try to distalize all the teeth, starting from the second molar, ending with the anterior teeth, and see the final result that I can get? Should I just extract one premolar, and by doing that I can probably fix the class 2 and get a better alignment of the upper teeth? Or should I just try to align the teeth and use some intermaxillary elastics and hope that I'll get the jump that I simulated with the software and be satisfied with that result? Not only I could see and visualize these different treatment plans, but I also could see how long they will take, if everything is equal, how long they will take to achieve all these movements. So starting from 24 aligners, which is around 6 to 7 months if we switch weekly, ending by 60 aligners if I do the distalization. And I could communicate this to the patient and make her decide with me which way she wants to go. And at that time, she decided that probably we should try and see if we can get anything with the class 2 elastics without extracting a tooth or without going and do a long treatment with the distalization. And after 30 aligners, this is what I was able to achieve to get. Of course, you need the patient to be engaged with you so you can get these kind of results because they are partner in the treatment. But this, I don't think this would have been possible without having a tool that would make me or help me visualize this without even putting a tray aligner or even a bracket inside their mouth. So let me pause here for a second and ask you this question. And you're going to see this in the pool in front of you. How do you think, or do you think that digital treatment planning is an effective method to communicate with your patients? Have you done this already, or what do you think about that? Okay. So please give us a few seconds here because sometimes it takes a little bit time for that question to be posted in the platform. So bear with me.
Yes, you will have it. You will have the question posted, and please answer the question not in the chat box, but not in the chat box, please. So 96 agree, 3% not agree, disagree.
Great, and that is exactly what I expect. The majority of you think that digital treatment planning that helps communicating with patients, and probably the 3% who answered that just hit that by mistake. Anyway, so let me start with the first part of my presentation for today. And this is the kind of cases that I think a general dentist would be able to handle with clear aligners, and if he does so, he would be adding a value to the treatment plan he's offering. The first two are probably pure aesthetic and related to orthodontics, which are the simple treatment, mainly relapse of a previous orthodontic treatment. And I'll talk about the spacing, which is caused by a tooth size discrepancy, or what we call it a TSD, and how this is really easily and very predictably managed by clear aligners. Then we'll talk about simple perio-restorative cases, and we'll talk about the simple restoring aesthetic and function with the easy cases and some interdisciplinary cases. What I will show you today is the kind of cases. I will not go through the mechanics and designing the treatment plan, because this is a topic for another day, and I hope we meet in another webinar and probably we can share some of that experience. Today, my goal is for you to look at your patients and your cases in a different way and think how you can add orthodontics as part of the treatment plan. For my dear orthodontist, bear with me. I'm saving the best till the end, so you will have your moment here, and you will see the kind of cases that I think clear aligners help us manage and in a different way. So let me start with this. We often see these in orthodontic practices, or even in dental practices, someone who had orthodontic treatment, and few years later, because they did not wear their aligners, or probably because of their growth, they had a relapse of the alignment. This patient had an extraction of 4 premolars, and of course she was not compliant. Most of teenagers, when they have their orthodontic treatment, they are not compliant with their retainers when they finish, and later on when they are adults and they are more aware of the problem, they start probably be more concerned and more responsible with their teeth. A case like this is easily managed, and not only that, it's easily managed with clear aligners, and the digitalization that clear aligners have, the component of using digital platform, helps you predict things that probably will surprise you if you are doing this with the bracket and wires. One of the concerns that we have is the level of the gingival margins and how to align that with during the orthodontic treatment. And when I designed that with the software, what I noticed is if we align just the teeth, we will end up with different gingival margins here. But with the software, I could change the alignment and plan on having the gingival margins on the same level. But now I have another problem, which is the dark triangle, just because where my contact point is. Of course, I have a difference in the level of incisal edges, but upper right one was had a composite veneer, and that was composite, so we could easily reshape the size of the incisal edge. The patient was planning to have veneers anyway because of the color of her teeth and the shape, and having a better alignment would help. So when aligning the gingival margins to get a better smile line will create a problem from aesthetic point of view, which is the dark triangle. But I can plan on having an IPR, or an interproximal reduction, or a stripping, which is trying to shave some of that enamel between the two teeth, or even the composite, so I can move the contact point higher. And by planning this in the software, now I know exactly how the teeth will look like even before I start. And not only that, the most important part is that I can communicate that to the patient before I start, so she is aware of all the steps. If I don't communicate that ahead of time and then I start or tell her that, or she would see that her tooth at a certain point will start being one tooth is longer than the other, and then she will have a dark triangle, and I'll tell her that I need to do an IPR. Probably she's not going to be happy or satisfied. But just because she knows ahead of time that this is all planned and this is part of the treatment plan, and she can see it ahead of time, will make that mission and that communication much easier. 16 aligner, which is roughly 4 months of treatment, and you get that everything is aligned, and now she can deal with this. That was had a root canal treatment, and that's why she was thinking about probably veneers. At that point, probably even veneers is not needed. She can do an internal bleaching, and then she can have bleaching for her teeth or whitening, and we get that result. Cases like that are easily managed and frequently faced in the orthodontic or the dental offices, where you can, patients can easily accept having another round of orthodontic treatment with clear aligners. But those who had treatments with brackets and wires, probably they will be more hesitant to have another orthodontic treatment, especially after the first experience. And this is how the final outcome, and you can notice that we did not alter the occlusion at the back there. I mean, she started with a nice occlusion and we kept that till the end. And the most important, we got all the gingival margins aligned. Now, another question here, and I'm asking the control behind the scenes, please help me with that. Who thinks that the spaces that we have between the anterior teeth can be sometimes challenging to treat? And sometimes you can get limited options or how to treat them, or the options that you have are not the best because they will not give you the best aesthetic result that you are looking for. So bear with me a few seconds and then we'll have this question for you ready so you can answer it, and we look at that pool. Here we go. So at least 93% or at least over 90% of you think that spaces between the anterior teeth are challenging. And I cannot agree more with you, because there is no single specialty that can deal sometimes with the spaces. Sometimes orthodontics can be done, sometimes orthodontics alone cannot do it, and sometimes prosthodontic alone cannot do it. But let me talk to you today about one specific kind of the spacing. Spacing between teeth or spaces between teeth has different etiologies or different reasons. I want to focus today on the one that has a tooth size discrepancy or Bolton discrepancy. And for those who don't know what the Bolton discrepancy is, or probably they forgot this from their dental education, this is where the sizes of the upper and lower teeth don't match. Usually there is a certain harmony or a ratio between the upper and lower, and there is a formula that we can calculate, and based on that we can know if we have this harmony or not. If that harmony is not there, or we don't have that ratio correct, then we can have one of two problems. Either we might have spaces between the upper or the lower, or we can end up with overjet or overbite. Today I will just focus on the spaces that can be created, especially between the upper teeth. This young patient here, she was 27 years old when she came, and her problem was only the spaces distal of the laterals, a little bit larger on the left side than the right side. Now, if you look at the dental arches, they are perfectly aligned. And I only have like a minor crowding of the lower teeth, probably of 0.5 millimeter, but I have probably 1.5 millimeter of spacing. And if you look at her occlusion, I'm not sure if I have it there. Yeah, if you look at her occlusion back here, she has a perfect occlusion, perfect +1. And I don't want to bother this at all. I'm happy. I mean, this is what we look at when we treat someone. We want to finish in this way. The power of digital treatment planning with clear aligners is that most of the softwares will do this for you. They will calculate the mesiodistal widths for the teeth, upper and lower. And not only this, they can calculate the Bolton analysis or the Bolton discrepancy, and they can tell you exactly how much discrepancy you have in millimeters. Usually when we do that manually, when we calculate it, we get that number in percentage, and then we have to figure out the numbers. Here I have this number ready to use for me, just with a click of a button. I know exactly how much space I need to create on the opposing arch, which is the mandible, to be able to close the upper spaces and maintain that occlusion in the best way. And not only that, I also can add just the IPR or the interproximal reduction to the value of the crowding I have also. So I can add this or consider it when I calculate how much and where I want to do the IPR. And you can see here I programmed or planned IPR distal of the canine to the distal of the canine on the other side, just because I knew this is exactly where I need the spaces. And by doing that, I was able to create that overjet or spaces between the lower where I could align and retrocline them. So I create that overjet, and now I could easily close that space without altering the posterior occlusion. And just with 14 aligners, 3.5 months, and this is exactly what we got. Addressed the patient chief complaint, closing the space on both sides, the right and left, and without altering or changing her posterior occlusion at all. Looking at her dental arches from the occlusal, and you can see no more spaces, and address the patient chief complaint the way we wanted. And that's how we started, and this is where we finished in just less than 4 months. And the most important thing is we could visualize this even before we start, just because we had the tools to perfectly treatment plan this with ease with using the softwares. And this is her smile at the end of the treatment. Now I have another question for you, because things are going to start getting a little bit more interesting and exciting. Who thinks that the patient occlusion is an important factor to consider when planning for restorative treatment? Oh, that's impressive that 100% of the audience believe that the occlusion is an important factor, and I couldn't agree more. Many of the failures that we have in dentistry, in restorative, are sometimes caused because we did not take the patient's occlusion into consideration. And let's look at a few examples here. Let's look at this lady here. This lady had a sad story where she had health issues, and then she was hospitalized for a long time, and she had to spend months in the intensive care. And during that time, of course, dental hygiene was not a priority. And what happened is she lost a crown during that time. And, we all know that once that happens, then probably you're going to have supra-eruption of the opposing tooth, and this is exactly what happened here. The other thing, she was not happy. She visited her dentist, who was a friend of mine, and we were looking into options to do the full mouth rehabilitation or restore her oral health and the function. So at that time, she also did not want that diastema to be present because she was not happy with it. But let's take a deeper look here and see what's going on. If you look at the lower teeth, you can appreciate that she has a lot of calculus between her lower teeth. And the other thing which is important here is the deep bite that she is having. Why this is important for her case? Because let's try to remember the importance of the ideal occlusion. And specifically what I want to talk about here is the anterior guidance of the upper and lower teeth with the protrusive movement and the canine guidance. We all know that when in the ideal occlusion, the lower teeth, the labial surfaces of the lower incisors will slide on the lingual surfaces of the maxillary teeth, and by doing this, they will open or disocclude the posterior teeth. If that doesn't happen, because probably we have a deep bite, then the teeth will have to travel longer space on the lingual surfaces, or the lower incisors will have to travel longer space on the lingual surfaces of the upper incisors. And because of that, there are two things that might happen. Either we might have a severe wear on the upper and lower incisors, which we see because the enamel would wear off. But the other thing that we can see also is the destruction of the periodontal ligament, because think about all the forces that these teeth are receiving. We might think that the etiology of the periodontal health that she has, or the periodontal issue here, might be something different. Might be because of the lack of the oral hygiene or the proper oral care, which is true. I mean, that can't be the reason. But if you look at the bone level all over her, for the other teeth, especially the posterior teeth, you don't see that problem, which makes me believe that this is happening because of the traumatic occlusion. Of course, at that point, the periodontist decided that these teeth are non-savable. We cannot save them just because of the amount of bone loss, and they had a grade 3 mobility. So the decision was to take them out and replace them with implants. You can see that she also had an implant before she had that unfortunate accident, and this implant was not restored. So, and fortunately the space was not closed, but probably they need a little bit adjustment. So the overall treatment plan for this lady is to try to close the diastema and try to open the bite a little bit by intruding the upper teeth. So later on, if we replace the lower teeth with implants and we restore them, we don't have the same problem, because if we keep the same problem that deep bite is there and teeth has to travel longer time, we will be abusing both the implants and the natural teeth, and we probably end up with the same problem. At the same time, we decided orthodontics can be helpful because we can open up the space for to restore or place the crown. Fortunately, that tooth had a root canal, so the prosthodontist decided that we can go ahead and restore it once he had the space for that. So this is where we started from. This is her occlusion, and you can see the diastema now from the occlusal view. This is where the implant is embedded in the bone, and that was the treatment plan. And when we did that with aligners, we planned on doing only the treatment for the upper. Nothing was done for the lower, but we decided to keep the lowers as a guide for us, just to know how much we intruded. If we took the teeth out, then what would happen after the extraction of all the lower incisors, we would not have any kind of reference point how much we are intruding. And the other thing is, once you extract the bone, and the gingival tissues will shrink, will be resorbed, and then we will lose our reference. So we decided to keep them, beside that she wanted them to be there for aesthetic reasons. And at that time, the treatment was relatively short, 26 aligners, and a little bit over 6 months. Closing the space, we knew that we will have a problem with dark triangle just because of the diastema, and she didn't have any dental papilla formed. So we knew that if we want to help that dental papilla to be formed, we have to move the contact point as close as we can to the alveolar crest point. And that's why we planned on having an IPR between the two centrals. But also we planned on intruding the first molar on the left side and on the maxilla, so we can create clearance, so we can restore that tooth again. And that's exactly what we did. This is how we finished that with 6 months. I wanted to do a refinement here just to get these aligned in a better way, but she was more than happy with what she got, and she didn't want to go for another round, and she wanted to have her lower teeth restored. This is, by the way, after we cleaned them the first time. She is from the kind that has or develops calculus fast. But look how much intrusion we got of the first molar here, and how much space we created. This is more than enough to be able to restore the crown. My point here is, just in 6 months with orthodontic treatment with aligners, which is a simple treatment here, we could give the patient a better occlusion, better alignment for her teeth, and now made the work for the prosthetic part much easier. And this is where we started from, and this is where we ended after a little bit over 6 months. Of course, at that point, we had to do frenectomy. We did the frenectomy after we finished the treatment, because sometimes, especially if you have a large diastema, what happens if you do it early is you create a scar between the two teeth, and then you have hard time closing that space. So again, let me stop you again with another question. I know that there is a lag between what my screen here and what you can see, so I will be waiting for a few seconds, and then probably you can see this question. How often you are faced with situations where you have drifted and supra-erupted teeth, and how much you think this would complicate the treatment? Okay, so again, more than 90% agree that drifted and supra-erupted teeth can complicate the treatment. I'm lucky today. I have a very nice group of people attending. They agree with me with everything I say, so thank you for that. No, let's get serious here. We all know that how much supra-erupted and drifted teeth can complicate our treatment, and this is another example of that. This lady was in her late 50s when I saw her, and she was the mother of a patient of mine, and she came with him to his appointment, and we were chatting when I was doing his activation. I was doing brackets and wires for him, and she was telling me about her visit to the dentist, and that she was complaining of having food being packed between the two premolars, mainly here, and she's not happy with the way they look, especially when she smiles. But when she talked to her dentist, they told her that the only thing they can do is probably make a bridge from the second molar, including the first and second premolars. And probably they were right. This is the only thing they could do at that time, because that space was, she lost her first molar, and then the second molar drifted mesially, and the second and first premolar drifted distally, which complicated the treatment. So now not only the smile is compromised because of the spaces and the rotations, but also the function, and she's having problems with the food packing between the teeth. But what can you do in such situations? So at that time, I asked her, if you don't mind, can I take a look and see if there's anything we can do? And she was surprised that we can't do any orthodontics for her at that age. But then when I looked at everything in a closer look, and I took a panoramic, I could analyze what's happening. Again, because we lost the molar very early, what happened is the second molar would drift, and the second premolar also drifted distally. You can notice that she has an implant here where to replace a missing canine. Most probably that canine was impacted and was extracted at an earlier age, but the only thing that makes me worry about this canine is it will limit my ability to move the front teeth, just because we know, I mean, we cannot move implants. But I was focusing on that area here. What can I do for her to help? Probably we can think, why don't we try to close the space by mesially moving the second molar? And you would be right if you think that way, but I want to remind you, look at how the roots are and how the crown is. Just because we have the sinus dropping between the two teeth, that will make it almost impossible for the roots to move and have a bodily movement of that molar to close the space. This is going to be the same problem if you wanted to place an implant. You need a sinus lift. But also for orthodontics, if you have the floor of the sinus dropping that way, I had bad experiences trying to close that gap or that space. So I decided at that time, because of that tipping, I can easily tip that tooth distally, open the space, and then she can have an implant. She can have an implant, and that implant wouldn't be large enough to replace the molar. It would be just a third premolar, but that will be enough to take care of the function and the aesthetic. If we can bring the premolars back where they were supposed to be and restore her smile with the front teeth, and open a space to restore it with a third premolar, that would be great. Probably we will need to extract a wisdom tooth later on, just because it does not have an opposing, but this is something we can she can decide on later. At least she is aware of the problem. This would happen whether she had a treatment or not anyway, or we can give her a retainer at the end of the treatment, and then we can keep the wisdom on the same level. And by retainer, I mean vacuum pressed or an SX retainer, where we can keep them from supra-erupting. So when I presented that for her, she was more than happy, and she wanted to go forward for it. We tried to restore the space that we lost earlier, and try to intrude the teeth, because she had some degree of a deep bite. And in 7 or 8 months of treatment, we were able to restore the smile, brought the canines, the premolars back to their alignment, and restored that space. And now we put her in the hands of the implantologist or her dentist if he will do her implants. And we made that job easier for them. Of course, she might need a sinus lift. She might go for a bridge afterwards, but both cases, we made this case easier to be restored from that point. Comparing the left side to the right side, I agree that, or I think most of you would agree with me that restoring this would be much easier than restoring this side. Now, let's talk about something different here. If you look at this patient, probably the first thing you will notice is the spaces between the upper and lower teeth, and you would think that this is the patient complained that his teeth are flared out, and having this diastema make his smile probably less aesthetic. And you are not wrong if you think about this, but if you take a look a little bit deeper, you would realize that we have a bigger problem here. This guy was 45 years old, and also he was the father of a patient of mine, and he just wanted me to look at his teeth and see if there is something can be done for his teeth. And of course, as I told you, you can conclude that he has a protrusion, a tongue thrust of and protrusion of his upper and lower teeth. We have a diastema problem, and frankly, yes, aesthetic is a problem. Procrastination is an aesthetic problem, but this is not what bothers me. What bothers me is if you look at the anatomy of his teeth, especially the molars here, you can appreciate the wear he's having, and his molars are almost flat. And if you wonder why this is the case, it's just because of this over here, where we lost the canine guidance, and this over here, where we lost the anterior guidance. So yes, orthodontic treatment has an aesthetic component here. They have diastema and the spaces, but this is not the problem or the only problem or the major problem the patient has. The major problem is, again, we lost the anterior guidance, and now because of that, the posterior teeth are not being disoccluded every time the patient is moving forward. And what happens is these posterior teeth are being beaten to death every time he is moving his jaws forward or sidewise. They are being rubbed against each other and losing, and there is wear happening on them. Remember, posterior teeth are not being designed or made to receive forces when they are being rubbed against each other, and that's why the anatomy for him was lost. So I explained everything to him, and he was very understanding. And actually, he was excited to get this diastema closed, so he didn't really care about the posterior bite. He understood the importance, but his problem was the diastema. So he was on board to get the treatment. And again, because this is being done digitally, I was able to design this with a high level of prediction or predictability. I knew that I would have the same problem that I have usually with diastemas, which is the dark triangle. So I decided to move the contact point a little bit towards the gingival, so I can probably help with creating that papilla. But also I knew that I had a tooth size discrepancy, and I needed to do some IPR on the lower so I can fully close the spaces on the upper, just like the case we presented earlier. So yes, we have spaces on the upper end. I'm sorry, can you repeat that again? Okay. Yeah. Before I finish with this case, I was asked by the control if everything is okay for you guys, if the sound is okay, and if you are okay going for another probably 45 minutes, because I think I need another 45 minutes to finish, probably. So, control, I will let you read the comments. I will just keep going with my lecture. Okay, so again, yes, we have spaces between the upper and lower, but the spaces that I had in the upper are larger than the lower, and I had a tooth size discrepancy, so I needed to create more space in the lower to be able to close the upper spaces in a predictable way. And in 22 aligners, which is a little bit over 4 months, little bit less than 5 months, we were able to close the spaces completely. And this is a case that's really easy to manage with aligners because they are proclined and tipped for. Well, thank you, guys. Thank you, guys. So again, this is a case that is easily managed with the clear aligners with the experience of a general dentist, just because of the etiology of the open bite. That etiology is because of the proclination of the upper and lower teeth. And just by tipping the teeth backward, which is easily done by any removable appliance, even especially clear aligners, you can retrocline the upper and lower teeth, and by doing that you can close the bite. And now you can see that we restored the function, not only the aesthetic and closing the spaces, which was the thing that he cared for, but also we restored the canine guidance and the anterior guidance. And you can guarantee now that these teeth will serve him for a longer time. So keep that in mind when you're looking at your patients. These days, whenever I look at a patient's mouth and I see that amount of wear at the posterior teeth, I know that I'm dealing with an open bite even before I ask my patient to close their teeth. So I'm done with my dear dentist, general dentist. This is the things that I think you should be looking at now when you look at your patients and see these kind of cases, and probably talk to your patients about how you can help them even better keeping their dentition if they can include orthodontics as a part of their treatment plan. I had my training in orthodontics, so orthodontics will be always in my heart. And now I'm talking to the group I like to talk to. Nothing against dentists, of course, but let's get things a little bit more interesting. So let's talk about a few cases that I found interesting, and I'll talk about some complex or periodontal cases, some complex restorative cases, how you can improve the facial aesthetic, dental and facial aesthetic, and improve the patient life and sleep quality with orthodontics, mainly with clear aligners, because this is the topic of today. Let me start with a case that I treated years ago. This is one of the cases, probably this is one of the early cases that I treated with clear aligners. And this guy was the father of a few, more than 3 patients that I treated. And he was referred by my friend who was with the periodontist. He was asking me if I could splint these teeth together, so probably we can extend their lifespan, because that tooth was already having some recession, bone loss, and second degree of mobility. The others were not that bad, but the patient was not really ready to lose any of the teeth. He just wanted to keep what he has. And then my friend asked me if I can just do one of my magic lingual retainers and keep the teeth together and splinting them, that probably this will keep them for longer. And I told him, you know what, I can do that, but I don't think this is going to help, just because of the spaces I have. He's going to break it in no time. Whenever you have spaces between the teeth, if you don't really make a very wide splint, it will break. And I was not prepared to do such splint at that time. But I told him, you know what, probably we can try something even better. We try to close these spaces and try to retrocline the lower incisors. And probably by doing this, we can bring the teeth back inside their alveolar bone, and we can hope that if the alveolar bone to be built again around these teeth, and hopefully the gingival tissue will be restored at that time. This is an advanced case for 2 reasons. First, we have some amount of bone loss, which makes it a little bit harder to manage in terms of biomechanics. My dear orthodontist know what I'm talking about. And the other thing, the amount of the spaces is really big, especially on the lower. And at that time, he accepted the treatment plan. Of course, he has the same problems of wear and abfractions, just because the patient lost the anterior guidance and the canine guidance. So you can expect that we have more problems with the teeth. But we thought that restoring these the function would start by bringing the teeth back to their initial position, and then long-term retention with fixed retainers that would serve like a splint at that time. So my treatment plan was trying to bring these teeth back to their alveolar bone, retroclining them, closing the spaces. The spaces will be closed by retroclining the uppers and at the same time moving the posterior teeth mesially, so all the teeth, the spaces will be closed at that point. It was a complicated treatment, and you can see that from the number of aligners, 41 aligners, and at that time I was doing, for him, I did more than 1 week just because I wanted to move teeth a little bit slower. So at the end of the 41 aligners, this is where we finished at. Teeth started healing and respond to the treatment as fast as we brought them back to their alveolar bone, and that was taking 2 months after we finished the treatment with the retainers. Another case that I would like to share with you, this is probably one of my first cases that I treated with Invisalign. At that time, I was trying to build my experience, but the reason why I choose Invisalign for her is for logistics. This patient was referred to me by the prosthodontist. At that time, she was 23 years old. She had a car accident where she lost all her front teeth. And now after she recovered and done with all the surgeries, because she had some facial trauma as well, she came back to restore her smile. And when I looked at that at the beginning, I didn't know where to start. The prosthodontist wanted me to just bring the teeth back or restore the shape of the upper arch. Let me show you. Yeah, mainly the upper arch here, wanted me to restore that, give it a better shape, better occlusion, so he can restore it from there. I said, fine, probably we can work on something. But the problem is, at that time I was practicing in Saudi, and this patient was studying abroad. She was in the United States, and she wanted something that worked for her. I thought, I cannot do it if you are not close to me, where I can see you at least once every 4 to 5 weeks, so we can do something. And I said, okay, I cannot work around it. So I thought, okay, why don't we think about Invisalign at that time? I'm sorry. Because probably Invisalign can help. And we can make the aligners, we can plan the treatment digitally, and then I can give her all the aligners with the instructions. She can wear them, and then I see her whenever she comes back. And she was on board. The advantage that Invisalign gave me at that time is being able to, sorry guys, with designing with the aligner, I was able to design or to add Pontex to the aligner where we could fill them with composite, and by doing this, we could give her something temporary to smile and to walk out with. This way she can walk, meet people, and have a social life without being embarrassed that she lost her front teeth. Unfortunately, I don't have a photo for that. I wish I could. If I knew I would be presenting this case, probably I would have taken one. But this is what I did at that time. So this is a panoramic, and you can realize how old this panoramic is. And this is how her occlusion was. So when I treatment planned this case for aligners, I was able to manage or to measure the space and have an idea how I want this to end. And I was able to communicate this not to the patient, but to my prosthodontist, who is going to take over and work with that. And based on that, I decided that we need to reduce the size of the lower teeth so I can create more overjet to compensate for the bone resorption and the shrinking that happened because of the trauma, the fracture that happened on the upper jaw. 24 aligners in total at that time. I asked her to wear each of them in 2 weeks. And I saw that patient only twice, the day I inserted the aligners and the day I stopped the treatment. That I gave her everything, and she came after almost a year, and that was the alignment I got. Of course, I had some decalcification of the enamel just because she did not remove the aligners at all, because not because she wanted the treatment to be done, but because of the aesthetic of the Pontex. With the Pontex, she was able to restore her smile and she was walking with confidence. But at that time, we knew that will be crowning most of the teeth. This is a collateral damage that I would prefer not to happen, but this is not the fault of clear aligner. This is the patient's fault. But my point is, we could restore or give a better start for the prosthodontist so he can restore that. Now he can place his bone graft and he can plan on his implants. When we delivered the retainers for these patients, we were able to place fake teeth, so she can use that as a removable prosthesis. And when we did that, now you can imagine or have an idea how the final restorative work will be. So even with the retainer, we were able to give her a smile that she can walk with in the waiting time. Probably this was taken after the bone graft, I think, and gave the prosthodontist a better starting point. Let's start talking about a little bit more interesting things. This is one of my favorite cases that I treated over the years. She was referred to me by her dentist. The reason she was referred because he was trying to restore, of course, she was concerned about the alignment, the crossbite on the left side, but he was trying to restore the function and the canine guidance because he was planning on replacing the lower crowns. If you look at the occlusal plane, you can see that occlusal plane is not a plane. It goes up and down. We almost don't have an occlusal plane. The upper crowns are much larger than the lowers, and that was because probably the old restorations that she had, they were almost flat, and she was looking for aesthetic results. My prosthodontist at that time, or her dentist, asked me if I can create space for him so he can replace these crowns with better anatomy, with a better occlusal plane, with a better function. And we worked closely together with that case. So again, this is her occlusal view, the lower occlusal view, and you can see that she has almost no anatomy or whatever for her teeth. They were almost flat, and that added more insult to the injury at that time in terms of function. She had some muscle spasm because of the kind of bite she had. This is her panoramic, and you can see that she had an extensive dental work, including too many root canals. That tooth was decided that is non-restorable, and the decision was to extract it later, but I asked them to keep it so I can use it as anchorage. This is her occlusal view. The other problem that we have is the shift of the midline. Her upper midline and lower midline did not coincide at all, and we had a severe shift. Now, when I treatment planned this, I did not only treatment plan for the teeth to be aligned and to get everything straight. And to get everything straight, but also what we decided to do is to open the space at the posterior and intrude the posterior teeth. And we phase this treatment in two phases. The first one, that we do the alignment, we do the intrusion. At that point, once we open that space, then I send her back to her dentist where he can do all the restorative work, and then he can place the crowns for me, and then I do a refinement stage where I settle the bite. And this is exactly what I did. This is the first set of aligners where we got everything aligned. We opened the bite both sides for her restorative dentist so he can place the crowns, and then at the second stage we took another set of impressions or scan where we planned another set of aligners just to get the settle the occlusion and have a better intercuspation at the end. And this is how we were able to restore that case in almost a year. These are the steps: getting everything aligned, opening the posterior bite so we can restore it with crowns, and then having the final crowns in. Another interesting case where we had to do a little bit of extensive work to get everything restored. This lady was in her late 50s when she came, and her dentist was trying to restore everything. Let me start with her panoramic so you have a better idea what's going on. She has some missing teeth. One side was replaced by implants, but look at the Pontic over here to replace the second premolar. Same thing here. She had a bridge to replace the second premolar. So it seems that she lost these teeth early in her life, and because of that, the teeth, especially the lower incisors, spaced out. And she was referred to me to close these spaces and splint them so she doesn't lose them. But in the same time, her restorative dentist was not happy about her bite and occlusion. She had an overjet, she had the spacing, and she had a deep bite. And the decision was made to try to restore the spaces in a way. We open a space for the second premolars, then she would redo the restorative on the posterior teeth. At the same time, we close the spaces between the anterior teeth. Looking at that from the front, you can see the deep bite that she has. She has the front teeth, and she has the supra eruption. Closing the spaces without doing anything on the posterior would make the problem even worse, because by closing the spaces, you will just deepen the bite, and that will add even more insult to the injury that she is already having. So we decided that we will open the spaces. After I sectioned the bridge, we opened the spaces for the second premolar on that side. The other side was not connected anyway, so we just opened the spaces using the implants as anchorage. In the same time, we were closing the spaces between the front teeth with the proper torque, so we maintained them inside their alveolar bone. And in a little bit over a year, because I asked her for more than 10 days wear for that aligner, we were able to open the spaces as planned, and then we moved her to the we sent her to her restorative dentist so we can restore these or replace the crowns and the bridge on the lower side, on her lower jaw. And just put this slide here to show you that you get what you planned, even in the occlusion. If you plan this properly, you get what you planned, as long as you know what you are doing. Restore the function, close the spaces, and restored her canine guidance. So now when we replace the crowns over here, we know that we are protecting them with the kind of occlusion that we created for her. You can see how much space we opened here, and now we can place a second premolar in full size. This is the lower up before and after. And you can, this is her panoramic before and after, and you can appreciate how much spaces we opened. And now we can easily place, restore this bridge and place another restoration here that will have the size of the premolar. Have two more cases, guys, and then we will be wrap up this presentation. So bear with me. If you look at this case, you realize what happened here. This lady is missing one lateral incisor, and she visited her prosthodontist trying to restore this, and he told her we cannot do anything without orthodontics. And at that time, she didn't want to do any orthodontics just because she hated braces. And even with aligners, she committed to 1 year of treatment. And she asked me if I could do it, and told her, yeah, sure, we can try doing this with aligners. And this is exactly my plan. I'll try to open the space for you so you can have your implant. Once you have your implant, you have the temporary crown on that. I will do another refinement so I can settle the bite. And she agreed to that plan. So looking at this again, you see that we don't have any space between the canine and the central. When we treatment plan this case, we treatment plan in a way that we open the space, we fix the midline, and once the space is opened to properly, then I sent her to my colleague where he placed the implant for her, and he restored that with a temporary crown out of occlusion, so it doesn't affect his the osteointegration of his implant. And at that point, once we opened that, we placed the crown. I took another scan and sent it for a refinement. And this is after we settled the bite. The treatment itself didn't take more than a year. Now, let me talk about the last thing that I want to cover with this presentation. I know that you got tired and probably it's too late in some of the countries, but I think this case worth some attention. So, of course, if you look at this, we know that she has an open bite. We talked about the importance of restoring the function and everything. But the etiology of this open bite is different than the one that we talked about earlier, where you can just step back the teeth. This is an open bite because of the growth of the mandible. If we look at her ceph, you'll find out that she has an anterior rotation of her mandible, contributing to this open bite, and she has an increased facial height. What the open bite is doing for occlusion, the wear for the posterior teeth, is something we already covered, we talked about, but we planned this in a way that we intrude the posterior teeth, and in a way that when we do that, when we intrude the posterior teeth, this will force the mandible to auto-rotate, and when that happened, when that happens, the auto-rotation of the mandible, that will close the bite and also will shift the mandible forward, which will make her facial appearance even better. Because we are doing this with digital treatment planning, I was able to decide that I need IPR for better relationship in the anteriors, and because I had some crowding and I did not want to procline the lower incisors to cause more opening of the bite. And also I was able to realize that I will end up with a class 2, so I added some class 2 mechanics to my treatment to fix hair bite. And with 34 aligners, weekly switch, this is where we got. Less than a year, I was able to close hair bite. And this is not the interesting part in her treatment. What is interesting for me is what happened here. Just by being able to do these mechanics, which is easily done with aligners, hardly done with braces. Dear orthodontist, you know this more than I do, how hard it is to intrude the molars without any auxiliaries at the posterior segment. I had this auto rotation, and look how much we closed from the bite and reduced her lower facial height. And you can notice how we could change hair profile just by doing this. Usually you would obtain such results by orthodontic surgery, but sometimes just by the proper planning and having some vision, you can change the patient's aesthetic by doing simple treatment. And I will finish up with this case here, and how our treatment sometimes can change the patient's life. This patient here, because of the malocclusion that you can see and the narrow maxilla, not only having aesthetic problem, functional problem, but also she has breathing problem. The narrow arch is always associated with narrow airways. If you look at this case, you can realize that we have a shift of the midline, crossbite on the left side. She has a functional shift when she closes, class 2 from the left side. Usually these cases probably would need some orthodontic surgery to be solved. When we look at this case here, or when you look at the relationship between the maxilla or the width of the dental arches and the airways, it's almost proven that constricted or narrow dental arches are always associated with narrow airways. If you expand the upper arches, you can get some expansion of the airways, and then you can help your patient breathe better and probably solve some of the problems associated with sleep apnea. So the idea here was, if we can look at the airways here on the ceph, how narrow they are. So in theory, we decided if we can restore the arch form by expansion, and we did that with just aligners. No skeletal expansion was done just because of the tipping of the teeth. If we could do this expansion and some intrusion of the posterior teeth, then probably we can force the mandible to shift forward, and this together with the expansion would open the airways for that patient. And look how much we open just from here to here. Of course, we helped the patient, we changed her appearance with the auto rotation, but also we helped her with her breathing here. Looking at her digital treatment plan, how that was a long treatment, probably 2 years, but it needed a lot of work, and in the 3 planes, distalizing of the molars, then expansion of the upper arch, and then retraction of the anterior teeth. But the patient wanted to do anything to avoid surgery, and she was very compliant and was able to get this treatment. And look at the number of aligners. This is like 72 aligners. There was another set of refinement. I was not able to finish this just with 72 aligners, but I think overall the final treatment worth final result and the final outcome and the improvement in her life worth that treatment. This is the before and after, and this is herself before and after, and you can see how we were able to close the bite and reduce the overjet from here to here. And this is the improvement in her profile. You can see the strain here to close her lips. Now she's closing without any strain. So in summary, what I want to say here that clear aligners made it easier for practitioners and for patients to consider orthodontics as part of their comprehensive treatment plan. And the power of digital treatment planning gave the practitioner a fourth dimension to visualize their treatment objectives and outcome from comfort of their computer screen and to communicate that to their patients. And that digitalization is the future of the dentistry. We are already seeing this in orthodontics with clear aligners, and this is just the beginning. Now, before I wrap up, I have 2 more slides that I want to share with you, but probably I want to have some feedback from you answering this question. How do you think it's worth it to considering offering clear aligners to your patients as part of the treatment plan? So good. I almost have 50%, 50% that yes, it's worth it, but I don't know how to do it, which is totally fine because no one knows everything anyway, and it took me years to understand how to treat with clear aligners, and we are here to help you with that. But the question is, what do I need to treat with clear aligners? Because most of you answered that you would like to consider it, but you don't know how to start. So the first thing is you need the basic knowledge of diagnostic and treatment planning. As once you have the skills, you need understanding of the principles of biomechanics, especially the ones for clear aligners. Of course, case selection is important and patient cooperation is important. If you have these elements, it's easy to treat with clear aligners, because without that, you can easily take a case that looks like this, very simple on top, and create a problem like the one on the bottom in the matter of few weeks. If you don't know the basics of diagnosis and treatment planning with clear aligners and how they work and how to treatment plan with them. If you want to learn more about clear aligners, their mechanics, how to look at the cases, how to design them, we designed a course completely to help you with that. I made that course because I went through the problems that many of us or few are going through, not really knowing how to deal with clear aligners. Companies usually want just to market for their product, and sometimes they don't tell you the full story, or I would say the truth, and how they work, and what are they good for, and what they are not good for, and how they actually work, and what you should consider. When I designed that, I designed it in a way that it will talk about the principles, starting from the biomechanics, difference between, or how do you move teeth actually with clear aligners, talk about the process, how do you start it, explaining how to use the software in a very efficient way, talked about the clinic, the patient and the clinic management, then management of different malocclusions based on which plane we are talking about. Is it the crowding, or is it the sagittal plane, or the vertical plane, or even the very complex cases, the interdisciplinary cases that require management in the 3 different planes. Talked about the problems that you might have with the clear aligners and how to manage them, and touch briefly about the retention. I keep updating this course that I created online frequently with new tips, new cases, everything I learn, I just added to that course. At the end, I just want to thank you for being patient with me today, for listening, and for being such a great audience. Most of you stayed till the end, which I really appreciate. I hope you enjoyed everything I presented to you. I hope you learned something about from what I shared with you today. I apologize for going a little bit longer than I thought and for probably running a little bit faster at the end. Thank you very much